thank you so much one more time. I know, I really appreciate that you came, because if it was me, I don't know if I would be so diligent to come. But in any case, I really appreciate this opportunity. This is great. I really love talking about my research, as you will see. And I am a sociologist, so I must kind of preface my talk with that slant. I'm going to be talking to you about inflammation, but I'm going to be talking to you about this from the sociological perspective. So I am interested in racial and ethnic disparities, and have been interested in that for a while, racial and ethnic disparities in health in particular. And one thing that really, really sparks my interest is, what are the mechanisms that are connecting race to poor outcomes, health outcomes for blacks, for Native Americans, and for Hispanics in particular? So what are these mechanisms? What's that black box? And I would like to convince you today that maybe inflammation may be part of that equation. It might help us push our understanding a little bit further towards what's actually happening in the body that connects race to health outcomes. Okay, so first of all, what do we mean by race? I'm sorry, this is not Sociology 101, but I still have to do this because I actually think that the ways we think about race have real implications for how we conceptualize the relationship between race and health, right? So sorry, I don't want to insult your intelligence, but I do want to propose several definitions of race, none of which, as you can notice, is purely biological. So I will put that aside. I'm not talking about the biological parts of race. Surely there are some things in our DNA that makes phenotypical differences happen. If you read the one proposed by US government, race as geographic origin of ancestry, you will see that that's probably the closest to the biological explanation, because we are tracing racial groups to large masses of land, essentially, right? So they will be kind of the closest. But when you look at how sociologists and anthropologists define race, we are really moving away from that. So for sociologists, race is a social intervention. It's a social construction that changes. It's dynamic. It doesn't stay the same. It changes with context. And the important thing is it includes valuations. And here is the crux. It involves valuations in the form of widely held cultural beliefs about inferiority or superiority of different groups of peoples. This is the crux, right? When I take this definition, I can use it to theoretically derive my model in which I can argue that there is more to race than just biology. That there might, for instance, be stress as a mediator between race and poor health outcomes. Because people of certain groups are experiencing the life world in an environment that devalues them. American Anthropological Association goes even further. If you read the definition, you will see that not only they say that race is a social construction, they also say that essentially it is a political construct. It's meant to justify certain political arrangements and certain structures of dominance in the world. Right? So guess which one I like best. Okay, so let me move on now. I'm sorry. Racial disparities in health. Infant mortality is probably one of the best indicators of population health that we have. Now, would you guys mind if I lower the lights a little bit? Would it help you see? I think it's kind of dim. Yeah? Okay. So I don't know if I can find the right thing. Okay. Is that okay? Can everybody see? All right. Okay. So, infant mortality, a very good indicator of population health across populations. And so you just glance at it and you see right away that infant mortality for American blacks, non-Hispanic blacks, is more than twice as high as that for American whites. That's a big difference, right? Now, what is even more striking about that the rates of infant mortality for blacks are higher than rates in some developing countries, like Chile or Costa Rica or Malaysia. And overall, if you take the population as a whole in the United States and you rank infant mortality along with other industrialized countries, you will find that the US does terribly. We are 27th in that ladder, which we shouldn't be based on the money that we are pumping into healthcare, right? So we shouldn't be there. There is something going on, and part of it is this sky high for a developed country rate of infant mortality among blacks. Here is another indicator. This is life expectancy. Life expectancy is another very good indicator of population health. It is broken down for whites and blacks and by years, and you can see essentially that blacks are lagging behind whites in the expected number of years that they will live. They are lagging. There is a gap in the last figure in this one. It is about 5 years. But when you compare, for instance, 1950s and 1980s, you will see that it takes blacks about 30 years to catch up with the life expectancy of whites. And you see that? So the life expectancy of whites here is about 69 years, and here for blacks it is 69 years, more or less. Right? So again, some evidence of disparity, pretty powerful evidence of disparity based on some of the best indicators that we have. David Williams, who is one of the leading scholars in health disparities in the United States, argues that racial disparities are large in magnitude. They are pervasive, meaning that they happen across various contexts, and they are persistent over time historically. I'm just going to show you some of the diseases in which we have documented disparities, and you can see these are actually some of the major killers, right? You have cardiovascular disease, cancer, diabetes, HIV/AIDS. You don't really need to go on. You see that the major culprits are there. What's even more interesting to me personally is that disparities happen in health care, not just in health. So we know that blacks are less healthy than whites, but we also know that blacks receive poorer health care than whites. Not only they have poorer access, that's one thing. They are less likely to get any care at all. Second of all, when they do get through the door into the hospital or into a doctor's office, they are less likely to get equivalent care as whites. They are less likely to get appropriate high-quality care than whites. And this is even after we control for excess factors such as insurance, type of insurance that they have, socioeconomic status, the type of disease and the severity of disease. So there is more going on there, right, than meets the eye, so to speak. So this is sometimes called the residual disparity that we cannot explain away. We have to say, okay, we just don't know. There is a racial disparity, but what's going on there? And that's what I'm interested in, okay? All right, so what do we not know? On the theoretical level, like I said, the model of mechanisms is very important. I just want to know why this social construction, this social invention of race, could actually physically affect people's bodies. How can it happen? This is a social construction. Why does it have such real consequences on the cellular level and on the level of basically leading to disease and exacerbating, making worse the process of disease? And then on the empirical level, at this point, we just have limited data that would do two things that I'm interested in doing. Measure the social factors well, which is not that easy. And number two, provide measures of the biological processes in the body. Usually we have one or the other because of the fragmentation of disciplines, right? So data sets that would combine these two are rare, and even rarer are those that do that on the national level or on the population level, so that I could make inferences about the whole population, not only about some convenient sample of respondents somewhere. So those are some of the gaps in the understanding that I try to address with my research. Okay, so let's get back to the puzzle that is motivating my research. So you can see here that this is the puzzle right here, right? So the connection between the racial background and these chronic diseases that we have here, which I can just call chronic disease. So what's that? What's going on there? What's the mechanism? So biological mechanisms are definitely going to be important. I want to know what they could be. And we have some ideas what they could be, but let me put it first, put a placeholder there first, and I will go on. Now, racial background. Okay, so the second question, and that's not the same question at all as biological mechanisms. The second question here that needs to be answered is, what is it about race? About race itself that might change some things in how the body operates biologically. What is it about race? And so I am a sociologist, so I will have a ready explanation for you. I will say there are some social and behavioral factors that are linked to race, and those are going to influence the biological processes. So there is a mediation effect here that you can see, but there might also be some residual direct effect even after you account for those social and behavioral mechanisms. So this is kind of the conceptual model that I like to propose today. What do I mean by those social and behavioral mechanisms, just to be specific? So I concentrate on three. One of them is socioeconomic status, which is definitely a tremendously important variable in determining health. I will show you some evidence, but let me just preface it with saying this is probably one of the best things that we have in predicting health of people on a variety of indicators. There are debates in the literature to what degree race essentially is explained in its effects by socioeconomic status. And I'm sure you have heard those debates, right? So basically, I have worked with physicians some, and this is the classic response I would get. So yeah, there are racial disparities, but really this is about socioeconomic status. This is about the fact that minorities have less in terms of income, less in terms of education, they have poorer resources, right? That's all. There is nothing more. Well, no, there is more. Data say that there is more. There is more, that even after you account for it, you will explain a big part of racial disparities, but you will not explain it all. So the second thing is discrimination, and I conceptualize discrimination as a stressor, and I argue that exposure to discrimination will lead to the activation of stress response, which we know very well is gonna lead towards the wear and tear on the body. It will lead to premature aging if the stress is continuous and chronic, and it will lead to earlier onset of chronic disease and poorer stress process. Right? So stress is one of those kind of smoking guns that we have to connect social factors to real biological changes in the body that happen and that may lead to disease. Right? So I will give you guys a few thought questions, or I would like to argue that discrimination is a factor, but I don't expect that you are going to agree with me 100% always, right? I want you to think about it. Is it plausible that discrimination is one of those smoking guns? And then lifestyle, and this is something that I probably don't have to justify, we hear about it all the time, right? So poor lifestyle in terms of poor diet, higher calorie diet, less exercise, is going to lead to onset of disease. There are disparities in terms of racial groups in how much they exercise and how much calories they consume and what kind of foods they consume, right? So this is the policy line. This is like we need to target those lifestyle behaviors. But I question, yes or no, I want to see it in the data. Is there an indication in the data that this could actually help if we are successful in targeting the lifestyle differences? Okay. All right. So here is some evidence on racial disparities in socioeconomic status, such as a very, very rudimentary figures. this is showing higher rates of poverty among blacks compared to whites. This shows higher rates of graduation from college among whites compared to blacks. So the socioeconomic differences are well documented. They are historically rooted, and as far as we know, they are not really going away, right? Not yet, at least. So what does it mean? So there is this disparity in socioeconomic status. Does it mean anything for health of minorities? And this is a slide showing life expectancy by percent of poverty, which is a proxy for income essentially, and by racial and ethnic group. And so what I wanted to show to you here, that there are these incremental increases in life expectancy as a person is getting richer, as the income is increasing for the whole sample. And then when you break it down by racial groups, it happens certainly among blacks and whites just as much. In Hispanics it's a little bit less clear, but overall that pattern is there too. But this slide is here to demonstrate that socioeconomic status has a lot to do with health. So people of poorer means are gonna be less likely to have good health. It's just that simple. So yes, I think it's a plausible pathway. We do need to look at socioeconomic status as a potential explanation for racial disparities in health. Now let's move to racial discrimination. And my question is, does it still exist? And you are probably not the right audience to ask for me to ask this, but I expect that if I ask the general population, the answers would be much more varied than yours, right? So does it exist? Is there a reason to believe that racial discrimination is a stressor? Is a real thing that happens in the society and that stresses people of minority origin to the point that their health could be impacted? Okay? All right. These are results of an opinion survey given to whites in 1990, but I actually changed the data and it hasn't really changed within the 20 years, unfortunately. The changes have been small. So these are answers to the question to whites. They were asked to rate people of African American and white origin on these traits, on these positive traits. So they were asked, how likely is it, or would you agree that that whites are hardworking, prefer self-support as opposed to welfare, are not prone to violence, and are intelligent? And then they would be asked the same about blacks, same traits. And so you can see that the endorsement of these positive traits for whites is just exorbitantly higher. It's a lot more higher than the endorsement for the positive traits for blacks. Now, if you reverse it, you might ask, well, maybe for positive traits, but what about negative traits? Maybe you wouldn't see quite the same pattern. You do see the pattern. It's reversed, obviously, for negative traits, but it's there, right? So people are still much more likely to endorse negative traits for minorities, especially for blacks, than for whites. So this to me is saying that the stereotypes among blacks are persisting in America. And again, I come back to this term, widely held cultural beliefs. Because this is culture, right? This is something that we have somehow gathered during our socialization from this culture, these types of beliefs. Right? So the stereotypes are there. Now, does it mean that discrimination is there? Do these beliefs translate into discriminatory acts? And that is crucial, right? Because if people just believe that, whites are more hardworking or more intelligent or something, but they don't do anything, so why would it matter? Does it translate into behavior? That is a crucial question. It's crucial for my argument because I argue that discrimination is a stressor. So the people who are subject to discrimination must know they are subject to discrimination. They must perceive discrimination. I am not saying that that's the only pathway. It is conceivable that people could be discriminated against, for instance, in the healthcare system, not to know about it, but end up with poorer health results because they receive poorer care. That's one pathway possible. I'm not quite talking about it. I'm talking about a person comes to the doctor, they are treated with what they perceive as less respect, which activates their stress response, which will damage their body in the long run. That's what I argue, okay? Okay, so I will stick with healthcare because this is an area that I'm particularly interested in. There is a classic study that was conducted in 1999, which might sound old by now, but honestly, there hasn't been much done that would trump it, so to speak, since then. This is really a classic study that is being put forth as evidence for the argument that bias in healthcare happens, and that it's not just stereotypes, that it is actual acts. So in this study, physicians were participants, and they were given vignettes of patients, and they were asked to make a diagnosis and make recommendations for future care. And the vignettes were videotapes with actors. The actors were trained, they played patients, and they varied by their gender and by their race, as well as by age and severity of symptoms, but those two last ones were not very important, so I will just leave them out for right now. So here you can see just the crossing of race and gender in terms of the actors that were used for this particular study. And these patients, these actors who were trained, portrayed patients with chest pain. They came to the physician with chest pain. Everything was held constant, right? Like everything possible, they were trained to present similarly in terms of symptoms, also in terms of their non-verbal behavior, so there is no bias there. And the physicians viewed the patient and they were asked what they would do, how they would continue with the diagnosis and with the treatment. And so you can see here that black women in this study were particularly disadvantaged. They were less likely to get a referral to specialist than white women and white men. So this was actually kind of the first groundbreaking study that showed that actually race in and of itself, not socioeconomic status based on race, not severity of disease based on race. By the way, I do want to say why I am making this note. One hypothesis that I have seen in literature is that the train wreck hypothesis. I don't know if you have ever heard about it, but physicians will use that term, train wreck, for patients who have multiple conditions, comorbidities. They come with neglected conditions. They are just very difficult to treat, right? And so the hypothesis is that for a variety of reasons, minority patients would come as train wrecks, or they would have more difficult conditions to treat. So, for instance, you could argue that it would be more difficult to recognize and to diagnose correctly if a person is coming as a very complex case, right? So, but in this particular setting, since it was an experimental design that could control for this is not the case, right? That has not been a variable that could potentially confound these results. So I want to show you just a little piece of my own research here. So I was very interested in this topic myself, and I thought, well, you know, this is all well and good, but we need to know, we need to be able to pinpoint the conditions under which this happens. And so I had the hypothesis that it happens under stress, under time pressure, especially. And so what I did, I did a study that was very similar to Schulman's study, except I varied time pressure that I put the physicians under. So they read the vignettes, they didn't see because I didn't have money for that. So I just had written vignettes, and I gave physicians time limit for reading it and for making a diagnosis and recommendations. And when I put them under high time pressure, you can see that they were less likely to refer the black patient to specialists. Well, actually, I'm showing for results for evaluating that they have angina. I had different dependent variables. It was all the same. So they were less likely to refer to specialists, and also less likely to say that the patient has angina, that the chest pain that they are describing the patient, that that's actually angina, that it's a real legitimate condition that could be potentially serious, right? I did consult this research with physicians, and they basically said, well, you know, oftentimes chest pain could be seen as an indication of, you know, reflux, or I don't know, I don't even remember all these other options, but less serious options than heart disease. So another thing that I kind of want to point out about this research, I was in particular interested in so-called implicit stereotypes and biases. And this is a concept that comes from psychology. Psychologists have been talking about it for decades, really. Sociologists only recently. But what this means, I think, really explains very well, to me at least, what's happening in the society today. So, I studied physicians, right? Physicians are among the least likely groups in the society to be racist, for good reasons. They are highly educated. Racism, explicit racial attitudes correlates with education. They go into a profession that, at least on the surface has kind of, you know, egalitarian type of value ethics, and they want to treat their patients well. They genuinely want to be objective. That's a part of their training, to be objective, right? To be objective, I don't care what kind of patient it is, you know, what they look like. I want to see the symptoms, and I want to make the correct diagnosis. And yet, we see these differences. So what's going on? So this is a population that is very unlikely to be racist explicitly, right? But my hypothesis is that it does not matter one iota whether you are educated, whether you want to be unbiased. You have lived in this culture long enough to be exposed to deep racial divisions, and those things get into our head. This is the implicit biases theory. So basically, the implicit biases are traces of experience with living in a deeply racially divided society. These get into our unconscious cognitive processes. Now, what is that? Automatic cognitive processes. We use them all the time. All the time. We use them to categorize things, to categorize objects, to categorize events, to categorize people. We do that all the time. It saves us cognitive energy. You see? Now the problem is that in terms of racial groups, we sort people into racial groups. That's what our brain is wired to do. The problem is that there are different valuations attached to these groups in our society. And that's where I started, with the definition of race, do you remember? And the valuations that I made such a big deal about. Now, categorization is all well and good. It really helps us. It helps us sort through complex cognitive realities. But the problem is that in case of race, there are valuations. So by using these automatic cognitive processes, kind of inadvertently, we get to these stereotypes that are attached to categories, and we use them. Now, when do we use them? We use them when we do not have enough cognitive energy. Because they simplify. They are heuristics. They help us when? When we are stressed, when we don't have enough time, when we don't have enough information. Now, if we do, what do we do? If we do have enough time, information, and all that, we will use this information to make individual judgments rather than use stereotypes to kind of help us to make quick sense of the situation. Can you see that? So to me, this is a powerful explanation of what's going on in the society today. Now, I don't say people are racist, well, certainly some are, but I wouldn't say this is the main explanation of what's happening in the society today. I think most people consciously try to be unbiased and equal to all, but they are victims just as anybody else who has been living here to these unconscious processes. Mazarin Banaji, who is one of the first psychologists who studied implicit biases, once gave a lecture that I attended, and I asked her, so what can we do, right? Like, I mean, are we all doomed to be racist? And she said, well, we can do a lot. But the first beginning of that all is to know that this exists. And she used a term that I remember since then, and it was constant vigilance. She basically said that if we are constantly aware that this could be happening in my head without me even knowing, we are going to do better. But this was a diversion. So, okay, so what I think is that stereotypes exist. There is evidence for that. I don't have to think that. I know that. But I think that the discrimination happens because of these implicit lines that are linking stereotypes to behavior. Now, for the victim of discrimination, it does not matter one iota whether the basis for my act as a discriminator is explicit or implicit. They don't care. They're going to be hurt by that, right? So the effect of that discriminatory act is going to be the same on the victim. And what is going to be the effect? Well, first of all, limited resources and opportunities, obviously, which in itself could bring poorer health. Second of all, the stress, which I already talked about. Third of all, which is kind of like a novel idea now, well, not totally novel, but it's been in the literature more recently, is so-called hypervigilance. And what that means is that a person who lives in a society that is racist and a person is of color, they are constantly thinking, okay, what will happen next? Is this person, meaning something different that they are saying, So they are in this constant state of low-level arousal, right? Stress response is coming in here. And if the stress is activated chronically, and if the body doesn't have time to recover, if it happens every day, in every interaction pretty much, it's going to get health effects. You cannot get away from that, right? If you are living in a dangerous environment, in an environment where you have to protect yourself or be on the guard all the time, that's going to have health effects. Acts of microaggression is another word that is recently used, right? Not big discriminatory acts, big acts of aggression, but tiny little things that happen every day, ignoring somebody or, just saying something that could be interpreted in different ways, those type of things. Okay, now I want to come to the third one, to the third group. Those are health behaviors, and like I said, I probably don't have to convince any of you about their importance for health. I just wanted to point out that African Americans have higher levels of obesity. Here I am showing a prevalence of obesity, but it is in particular black women, not so much black men. So when you take the whole population, you will see the difference, right? But it is mostly driven by women. Alright, so I want to come back to this puzzle that I proposed, and I tried to go over these social and behavioral factors kind of one by one and setting up my stage to convince you that they are plausible as mechanisms. I don't want to take anything for granted, right? I wanted to support everything with the data that we have from other studies. Now I want to come back here to this biological mechanism. So there are some that we know about that are potential explanations. Stress is one of them, but I want to talk about inflammation. And you have come for inflammation. I didn't really get to it yet. I'm sorry, but I'm getting to it now. And I'm sorry if I disappoint you. I am not a specialist in biology of inflammation. I use the inflammation because it is a potential link between race and between some of the main public health problems of today, right? Chronic disease. So I use it because there is evidence from much better minds than I am in the biology departments that this thing, the systemic inflammation, is a precursor of just about any chronic disease that you know about. It's not specific just to cardiovascular disease or just to cancer. It shows in just about all of them. Okay? Now, I want to tell you a few words about what systemic inflammation is in my understanding, okay? And as I say, again, I'm not an expert, but I use this as kind of a tool to get to answer questions that I'm interested in. Okay, so inflammation. Inflammation is essentially an immune response. You cut your hand, right? So what's going to happen? You're going to get some pain, you're going to get some redness around the wound, you're going to get some swelling maybe, some feelings of hotness. Those are the signs of inflammation, right? So inflammation is an immune response. It is essentially helping the body to heal. It can be measured in the body by biomarkers. There are several types of inflammatory proteins that get released into the bloodstream and that essentially help with the process of healing of the wound. Now, in a healthy person, once that wound has healed, those biomarkers of inflammation are going to go back down to normal. But there are cases when that doesn't happen, and when these inflammatory markers are going to stay chronically elevated. Even though there is no wound or infection or injury or anything that we could track them to. So that person is healthy on the outside, but they are displaying these elevated levels of inflammation markers. Now, as you can see, this is linked to a bunch of stuff that we don't want to happen. The chronic inflammation is linked to these types of diseases. They are all chronic diseases, as you can see. We don't want any of them. We want that inflammation to go down. But I want to show you right now what I want to do with this inflammation as a kind of a tool for me to get to my question. So I will derive some hypotheses from my bottle. So first of all, I want to know whether blacks have higher levels of inflammation than whites. Now, what would that do for me? It would basically tell me that there is something biological that we know is a precursor to a bunch of diseases that differentiates between blacks and whites. So I would be getting at that one biological mechanism. Can you see? If I can show this. So that's hypothesis one, and then this is the one that is closer to my heart, the number 2. Now, if there is a black-white difference in inflammation, I want to know why. I want to see whether I can explain it, whether I can explain it away, or at least partially explain it by the common culprits, by socioeconomic status, lifestyle, and perceived discrimination. It would be nice if I could, because there would be nothing left. But do I think that I will? Why? Because I think that there is just more to race than we can measure. It's just a tremendously complex thing. I was at a lecture by Paula Braveman yesterday. You guys have been too. And she was talking about socioeconomic status, not so much about race, but she was proposing these incredibly complex models of pathways that connect socioeconomic status to health outcomes. And she was making a point that basically there are just so many ways through which the links can go that we cannot possibly fully account for all of them, right? There will always be something missing, so we are kind of making the incremental progress with what we can. Okay. All right, my data comes from a survey of midlife in the United States. This is a nationally representative sample, which is good for me because I'm a sociologist. I want those samples. I want to make inferences about populations. And the very wonderful thing about this data set is that it measures socio-demographic characteristics, including socioeconomic status, obviously, but it also has racial discrimination measures and it has biomarker measures, so I can get at that inflammation, right? All right, the biomarkers come from a sub-study. It's a smaller sample where participants were invited to stay at the clinic overnight. And the good thing is that since they were at the clinic, there was a trained person to measure their body weight and their height and also waist and hip circumference. which is very important because we know that when we ask people to report these measures, they don't know. Or maybe they know, but they won't tell you, right? So it's important to have anthropometric measures. And then in the morning, they gave a fasting blood sample, which allows for accurate measurement of inflammatory proteins. And there were three that I was looking at here: fibrinogen, C-reactive protein, and E-selectin. How did I measure discrimination? So the survey that they were given contained two scales measuring discrimination. One of them is called daily discrimination scale. That one, by the way, was proposed by David Williams. And respondents are asked on a day-to-day basis how often they experience various acts, some of which are these acts of microaggression, right? So they are treated with less courtesy or respect. They others think as if they are not smart. Others act as if they think that they are not smart, and so on. Another measure that was there is called lifetime discrimination. That's a little bit different story here. Here people are asked to count the number of times that they have experienced discriminatory events in their life. And so this is kind of like the more serious stuff, can you see? So they were, for instance, fired from a job, or, I don't know, they were given inferior medical care. So this doesn't happen every day, but when it happens, it's a big blow, right? So people were asked to count that. Not only, so this is perceived discrimination. People must believe that they were discriminated against to report an event. And they were asked to report events based on race, but also on other characteristics, such as, I don't know, sexual orientation or gender and so on. And interestingly enough, since I kind of look at that literature, it seems that the effects of perceived discrimination on health don't really differ. It does not matter whether you think that you are discriminated based on your race or of your weight or sexual orientation. It's going to have the same effect. And see, this, to me, this is another piece of evidence saying it is the stress response. See? It's not something inherent about race or racial discrimination. It's stress. It's like this basic physiological mechanism that if it is activated over and over and over again, it's just going to wear down our body. Right? Okay. I used linear regression with the robust standard errors, and I also used Oaxaca blind decomposition, which just allows me to get a little bit more precisely at quantifying what part of the white-black gap can be attributed to each known characteristic. Now, those of you who do multivariate modeling know what I'm talking about. The difference is kind of subtle. It is also a linear regression technique, essentially, but it just gives me these nice percentages to tell you, okay, I don't know, this many percent of the gap happens because of the different socio-economic status between blacks and whites. So my dependent variables are the biomarkers of inflammation. There are levels that are continuous variables. And I explain them by race, by several lifestyle factors. See, I have two measures of weight status, BMI, body mass index, and waist to hip ratio. And then I also have physical activity and smoking. Those are self-reported, however. And then I have the two measures of discrimination. And for socioeconomic status, I am just presenting results of education. I have done variants of my models with income, but income had a lot of missing values, so it reduced my sample, which I didn't like. and also it did not perform for some reason. It just did not show significant effects in the direction that I would that I could explain. Or I just left it out for this presentation only. But it did not change the results for anything else. It didn't change the results for education or discrimination or anything like that. Okay. These are just the sample characteristics here. So you can see how that sample that I had, since this was a relatively small sample for population-based studies, how it really broke down. And you can see that there are clear, significant differences in the levels of inflammation between blacks and whites. They are actually striking. They are large. They are all the way up there. See the inflammation markers? They are big. They are highly significant. There are also differences in education, as we might expect. Differences in BMI, also in the direction that we might expect, with African Americans having higher BMI than whites. There are significant differences in smoking, such that blacks smoke less, which kind of surprised me. That most of studies that I know show no significant differences between blacks and whites. I don't know about much of anything showing that blacks would smoke higher, but in my sample it was even less. And then vigorous exercise in the expected direction, unfortunately, with less exercise among African Americans. The discrimination differences are huge, as you can see here. They are particularly huge for lifetime discrimination. Can you see? So 0.8 events, hardly any, between 0 and 1 event of discrimination reported by whites, and 3 discriminatory events reported by blacks. That's big. This is kind of interesting.
But with a standard deviation of 3 also.
Yeah. So basically, the whites are all around.
Blacks.
Yeah, they are all around. So there are some that have 0. You know, there are some that will have, like, I can't remember what was the top of that scale. I want to say that it was stopped at, I forgot.
You got a range of 0 to 8 there.
No, but they could report number. So it was like, wait a minute. Okay, let me check.
It's not important for go on with your. I was just.
Yeah. Okay. So I did use one for each. Okay, so 0 to 8. But anyway, yes, they are all around. Yeah, and there are actually explanations for that too. There are theories for that too. There is, in particular, a theory that blacks are actually underreported. And do you know why? The theory is that they just don't want to think about it. They explain their experiences by something else. Because if they explain it by their race, which is an attribute that they cannot change, they don't have any control over their life. If I may, I will just make a very small sideline. I also do a research which doesn't have much to do with socioeconomic status and race on cancer survivors. And we asked them, about their adaptation. These are recipients of bone marrow transplant up to 20 years after the transplant. And we are asking them about everything. It was a qualitative study, their life, their adaptation. Now, one thing that we really found was that these people did not want to even touch on discrimination. When we surveyed their work histories, there were clear instances of discrimination based on their cancer status, based on their health, right? They were fired, they were denied promotions, they were promised things that they were not given then, and when we asked them explicitly, have you ever experienced discrimination based on cancer? They would say invariably no. And then we would ask, why was it that you were fired? They will give you all kinds of reasons. Economic situation, company policy, this. So my idea is about this, that people just don't want to admit discrimination because it disempowers them. It attributes negative events in their lives to something that cannot be changed. So that's my kind of, okay, that was just a sideline. All right, I won't hold your breath anymore. These are the results. I have unadjusted differences as red bars. These are essentially just the raw differences between blacks and whites before you account for anything else. And you can see here that they are, up to 0.5 standard deviation, which is, certainly nothing to neglect or to dismiss. When you adjust for the factors that I talked about in the yellow bars, the differences remain significant, but they get reduced by about a half or so. Now this thing, the yellow bar here and here and here, that's the net effect of race that I cannot explain away. I can't make it go away. I have plugged in all I know about to plug in, and I had in the data, right? I had socioeconomic status, lifestyle, I had discrimination, I had some socio-demographic characteristics such as age, gender, and so on. And I can't make it go away. So that's a challenge for me, right? Oftentimes when I see studies of this sort that have some socio-economic status, lifestyle, blah, 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 and they don't have discrimination, I say that has to be discrimination. And people make that inference, right? They say, well, whatever is unexplained about race, that we cannot go away, especially economists do that. That's discrimination. They actually have formal models of measuring discrimination by whatever is a residual after they have plugged in everything. After seeing Paula Brayman yesterday, we probably know better, right? One of her points was that even if we just look at something so simple like socioeconomic status and we think, oh, we know that, we have that down, income and education, maybe occupation, if you want to be really clear. She says, no. There is wealth that widely differs between blacks and whites. Wealth is a resource, whether or not you own your house. And I don't mean just own as having a mortgage. I mean own, have it, like be able to sell it if you need to, or be able to use it as an asset. Family assets. Those are all buffers that can help us in times of stress. And this is what differs. So a black and white person in the same job with the same income, which also doesn't happen as you guys know, but let's say there are two people like that, are on average going to have widely different assets that buffer their stress. And there are neighborhood effects. Blacks and whites of the same income and same occupational level and education have differential likelihood of living in different neighborhoods. Right? That black educated professional is still more likely to live in a disadvantaged neighborhood because their family lives there. You see? Okay, so there is more to it. Anyway, so those are my unexplained differences. Anyway, I will take the differences that I did explain and I will decompose them. I'm going to decompose them into the segments that correspond to all the variables that I plugged in. Okay, so this is called Oaxaca blind decomposition. Actually, I will decompose them in so-called differences in characteristics. So those are just the variables that I have been kind of bothering you with all along in this hour. But there are also interaction effects. So these are differences in how these different characteristics, such as socioeconomic status, translate into health for different racial groups. It's a different thing. That's not the same. So, for instance, from studies of income, we know that education does not have the same payoffs in terms of income for blacks and for whites. Whites benefit more from each additional year of education in terms of their paycheck. And something like this could be happening in health too. Blacks could potentially benefit from higher socioeconomic status less than whites. You see? Can you see those two parts? It's kind of hard to get your head around. One of them is just that blacks are poorer. That will explain part of the difference. But then there is also the differential effect of socioeconomic status that can add on to it. I need some notes, especially from my colleagues, because I know that they kind of meddle in these types of things all the time. And I just want to make sure that I explain it. Okay. All right. So these are the results. If you look at this slide here, the black-white difference, this is essentially the raw difference between blacks and whites that I predict. I predict with my equation. And the number is there so that you can see what part of it could be attributed to just the differences in characteristics of blacks and whites, and what part could be attributed to the differential effects of these characteristics on health. And again, I'm not seeing enough nods because I think it's just like it's all like gibberish kind of, like the language. But
you're looking at an interaction effect,
yes,
right?
exactly.
If you have
Yeah,
several variables,
that's right.
then they can each have an effect.
Right.
But some might have an interaction effect and some might not, and it depends
Exactly.
on the correlation between
That's
these
it.
strengths
And
of the
this
effects.
technique allows me to kind of parse out that gap into this, okay? All right, so this is how it flows out when I actually parse it out. This is fibrinogen, E-selectin, and a C-reactive protein. And so I have kind of gone on the lenient side all the way to P of 0.10, but you know, it's clearly marked, so you can see. But when you kind of overall look at this, first of all, there is one conclusion. It's hard to explain. The gap is hard to parse out because hardly anything is significant, right? With the exception of BMI. The BMI explains a good portion of the black and white gap. Here it explains 54% of the gap. Here it explains 44% of the gap, and here 72% of the gap. Now I want to say that these are results for the characteristics effects. So right now these are not interaction effects. It's just the coefficient effects.
Yeah.
So
So my question was going to be the effect of diet, but I think you're picking that up with the BMI.
You are. BMI is actually one of the best proxies for diet that we have. Yeah, and I didn't have a good diet in my data, but my colleagues who actually do this stuff, Liz Baker in particular, is not here, tells me that BMI is essentially diet. Like it's as closely linked as you can get. Yeah. Okay, so that takes the cake. That takes the cake right there. Discrimination is somewhat important, at least it's important in one indicator of inflammation in fibrinogen, but only lifetime discrimination, not daily discrimination. Daily discrimination doesn't do anything. Now, admittedly, I did plug in both of them in the same equation, so they, you know, are kind of, they are related. They are not collinear. Like I did not have a problem of collinearity, but if I did plug them in one by one, I would get significance for daily discrimination as well. But the lifetime is probably more potent since it comes out in a fully controlled model. Okay, so what's all this about? So BMI, you know, BMI explains the differences in inflammation, but lifetime discrimination is important at least for one of the markers of inflammation as well. Now the thing that I kind of was surprised by was that it is as important as BMI for the one marker of inflammation. It explains 51% of the gap, the other one 54%. So that's pretty much it. You know, all of the differences explained by these two. Can you see? Then there are some small, tiny pieces as well. But now, what I wanted to do now, I wanted to show you kind of graphically the representations of the interaction effects that I didn't have in that table. And this is the effect of BMI on E-selectin, a marker of inflammation for blacks and whites. And you can see that it works really well for whites and doesn't work at all for blacks, right? That line is non-significant for blacks. So blacks are essentially not hurt by high BMI in terms of their inflammation. Now this is from a fully controlled equation where I also had waist to hip ratio. Now what's happening with waist to hip ratio is right here. You can see it's totally reversed, right? So blacks, in terms of inflammation, E-selectin, blacks are responding to a different measure of weight status. Now what does it say to me? Well, it basically tells me that, first of all, there might be slightly different processes going on there, right? Second of all, we just need to pay attention to these measures, because usually we measure waist status by BMI, right? That's what we do mostly. Waist to hip in few studies we do, but in this one it's important because it's predicting inflammation for blacks, for the disadvantaged population that we want to figure out how to help in terms of losing weight, right? Okay, so let's see. So yes, differences between blacks and whites in terms of inflammation, I have absolutely no doubt in my mind that there are. Like, that was so clear from the study. That was actually one of the very few variables that was significant. Can I explain it? Somewhat. Somewhat, okay? Not as well as I wish I could. I can somewhat explain it by lifetime discrimination, and by BMI, by these two, right? So what does it say? So BMI is one of those things, as you said, proxy for diet, essentially, right? Lifestyle, right? Okay, all the policies are going into this. Should they keep going into it? Well, probably yes. But I want to say it is more complex. My conceptual model could potentially be much more complex because the BMI itself might be determined by things like discrimination, which increases stress response. So to me, the second result of the discrimination being important, at least for something, in an equation where pretty much nothing else is significant, that to me is more important. Because that says, listen guys, there is something about structure of this society that makes people sick. And before we figure out ways to address that and to dismantle those harmful structures in the society, we are not going to be able to do it effectively, to improve the health of the population effectively. Fundamental cause theory, right? My sociology colleagues know what I'm talking about. There is this theory in sociology which says basically socioeconomic status, but race as well, there are some scholars that put race in that category too, is a fundamental cause of health and disease, meaning that it is a cause of causes. It is not a proximate mechanism that we can address by some policy, just get rid of it, and have a healthy population whatsoever, magic bullet. Because it's a cause of many other causes. And if we dismantle that one pathway, there will be another pathway that will take its place. So what do we need to do? We need to go to that cause of causes. We need to go to that unjust racial structure. Okay. And we need to do it by talking between disciplines. Thank you.
Couple minutes for questions.
Okay, just a really quick comment and then a question. This is just sort of, I read the other day that in 2013, I think around, it would have been November, December, Science magazine named immunotherapy the finding, the advancement of the year in cancer research and heart disease, so it just kind of supports what you're saying. But also I'm wondering, is it possible, or have you looked at the possibility of this chronic stress and inflammation possibly then leading to like epigenetic changes that then are passed along generation to generation?
It's so interesting that you mentioned it.
Mess, I mean, yeah.
It's so interesting that you mentioned it. There was this Disparities conference yesterday, and this is something that has been at the forefront of people's discussions. So I don't have epigenetic data at this point, but certainly this is something that sociologists are starting to think about. Intergenerational transmission through epigenetics, right? So basically, that was, I'm glad you pointed it out because that was something that really sparked my interest. That basically when we measure socioeconomic status, we are completely leaving out the part of socioeconomic status that is creating in utero environment. So if a mom is poor, the baby is going to be, while it is in the womb, poor. We never really pay attention to that. We measure socioeconomic status, at birth and so on and so on. But by that time, the organogenesis has been done, pretty much the pathway has been set. I will just say one more thing that just has been on my mind. I have been just thinking about it the whole day yesterday. Cesarean section. Much more likely among poor women than among high-income women. Tremendously more likely. And among minorities as well. Recent research is saying that this might be part of the reason why poor are more obese. Now, did it get your attention? It got mine,
yeah.
Right? Okay, why? There is microbiome in birth canal that the baby gets encased in when it's going through the birth canal. And that microflora is helping to prevent obesity. And the baby who is going through the cesarean section is not getting it. Antibiotics poor babies are much more likely to get antibiotics as infants and as little children. Kills all that microflora. So I'm just saying, there is so much more that is linking socioeconomic status to health, and we don't even, we don't fathom it. It comes out and it just blows our mind. But that's what I was saying, there is just a lot of the pathways that are linking race and socioeconomic status, and if we kick out one, there will be 3 others that will take their place, and that's why we need to go to the fundamental causes. Okay, I'm sorry, there was a hand somewhere, and I said 1 more minute. Thank you.
A major thesis, of course, of yours is that discrimination between whites and blacks in our society is a stressor for blacks, and you explained a lot of that. What I wondered was whether or not in other societies in which there is discrimination, but it's not whites and blacks, it's different kind of groups, for example, where they might all be white or some version of that, whether or not there's studies that suggest that the stressor phenomenon shows up in those societies.
It does. Like the ones that I do know, and I obviously don't know everything about all the global science, but yes, the ones that I know that there have been done studies on Turks in Germany, on Romani, Gypsies in Central and Eastern Europe. I think there have been some other minorities. There have been done some studies on in and out group stereotypes and the effects of that on in Israel. So the ones that we do have are certainly suggesting that this is happening. Now there is even kind of like a more general literature in social psychology on in-groups and out-groups, right? So it's not necessarily a specific ethnic group, but it is usually experimentally assigning people and experimentally creating in-group and out-group statuses. And this is also suggesting the same thing. So they don't usually measure, like long-term health outcomes, but they do measure stress response by salivary cortisol or something like that. Yeah.
So I guess one of the things that someone might suggest if one just looked at the data about how doctors reacted when they were under pressure is that there should be a protocol that they would enact and do this consciously when they had a minority or low socioeconomic patient or someone that they knew there was evidence. But I think what you're saying is that's not going to take care of the problem.
Well, if they do, okay, so there are two things.
I mean, consciously they could undo that particular effect.
So I think there are two things in your question. So there is one, would formalization of the care help? Basically, there is, and there is a lot of movement towards formalization of care, right? Electronic health records, electronic diagnostics tools and so on, right? So formalization, best practices, all that kind of stuff. The question to what degree this helps to reduce disparities is unanswered. We just don't know. We don't have enough data. The second question, in my opinion, yes, it would. I think it would because the leeway that people would have to make judgment calls would be reduced. And we know that stereotypes and the unconscious cognitive processes work best, well not best, work most in this case of ambiguity, uncertainty, clinical uncertainty. So in my opinion, yes. Now the second part of your question was, okay, I forgot.
Well, the thing is, okay, so you agree that, I mean, not necessarily agree, but you believe that would have a positive effect and reduce the medical care disparity.
Now listen though, in case it does not increase the stress of the physicians, and that's the biggie because they hate it. They hate formalization of care. They hate anything that increases their clinical autonomy. They want that clinical autonomy. They don't want the rules and they don't want to do bureaucracy. So I don't know how it would be possible to disentangle this in a real life. It wouldn't. It just needs data. We need data to see, to compare practices that are using this and to those that are not using it and see how they are treating white and black patients. How do they do on indicators?
let me give an analogy that occurs in education. Most faculty who grade a quiz in mathematics will know what right work should look like and what wrong work should look like, but they don't use a rubric. They might have a grading scheme, but that's different.
Right.
They're not looking for qualitative differences in a student's explanation typically, but they're looking, was it done right up to this point? Was it done right up to this
Okay,
point? Was it
okay.
done right up to this point? One of those they hold in their head, and that is, was it done right up to this point? And since rubrics are not common, they would have to look at it
Yeah.
and then consciously compare the student's answer and maybe exemplars to what they're seeing in a particular student. There might be a way to get them and to get physicians, if you take this burden of having to keep looking over at the rubric every time.
Right.
I don't know how to do it, but any more than I know how to change how mathematicians grade quizzes.
I think it's a big problem because there are these two separate pushes, right? The push towards formalization of care, which has this kind of motto of improving care for everybody, meaning it will also improve the care for blacks and hopefully more so than for whites, so we get to the equal plane. So that's there, but then there is also this pushback from physicians who could not care less for these things. They just don't. It's a new
And
way
they
of
are
doing it.
already consciously not discriminating.
Okay, so that was the second part of your questions. Question. First of all, physicians are terribly uninformed about these things. They don't get education. They don't get to hear this in medical school. Second of all, when they do get to hear it on occasions, they will be as resistant as you can get. And I have talked to a bunch of physicians about my research. Like they will say, there is no way. There is no way. No, because I am accusing them of being biased, and all I try to explain to them, no, I am not. I am actually trying to help you. They will not get it, right? So they are resistant toward even hearing about it. If they do hear about it, is it possible to change? I think so. I definitely think so. I think that just the simple knowledge of the fact that just by the virtue of having grown up here, you are going to be likely to treat your black patients differently from whites, that can already start doing something good, because they don't want to do that.
Let
They want
me
to
catch you
change.
real quick on that. There's one factor here that's I think, a critical variable that triggers implicit bias, which you indicated earlier in your work, and that's the time pressure. If you're a practitioner with 25 more people sit down in the waiting room to get in, that's where it happens. That's probably where you need to change it too. It's not just
The organizational structure.
Yeah.
And if I had all money in the world, I would just design an experiment. I would basically vary the time that physicians have for patients and see what it does in terms of quality of care for different groups. I don't have that kind of, it's one of those thought experiments more than anything. But
Sure.
but I think if I was to give one recommendation to organizations to improve equality, I would be give your people enough time and enough information to make decisions.
What about black physicians?
They do better.
Black patients?
They do better. They do much better on just about every.
Or were they discriminated against whites?
I haven't seen evidence of that.
I
I haven't seen evidence that it would get reversed. It might get more equal.
Yeah.
Now the problem with black and white black physicians and white patients is in communication. You know why? Because white patients feel uncomfortable with black physicians because there is a reversal of the roles to what they are used to in the society. So the communication is harmed by that, but more from the side of the patient than of the physician. Black physicians perform marvelously on communication. They do better than white physicians, especially in nonverbals. They do better. They do better, and you know why? Because they have to try. They are in that position of, you have to be better, smarter, more hardworking than anybody on the floor to be able to advance.
I've seen some bad research though about, not kind of negative, about black male physicians and black female patients. So that's an interesting dynamic there.
And I don't know because I haven't read anything breaking it down by gender that much. But I do know from my own research that black physicians in my study did marvelously on nonverbal communication. They did better than white
Thank you
Thank
very
you.